We are coming in at 12 o'clock, and if nothing else, in my time in Minnesota, I've learned that punctuality is important in the Midwest, so we're going to get started. Welcome everyone to our, this might be our first true official dockside chat. I'm trying to remember if April was dockside or not, but now at least I know for a fact that the ice is off Lake Minnetonka. So that's our best way of determining whether we're going fireside or dockside. And this is a program that's sponsored by the Medical Industry Leadership Institute, and particularly our evaluation lab, in support of our great programs that we have overseas, particularly our Global Medical Industry MBA program, now accepting new students for overseas programs with scholarships as well. We're pleased here to have with us John O'Brien, who's the President and CEO of the Pharmaceutical Manufacturers Council. John and I have known each other for going on probably nearly a decade, John, if we actually stack all the things out in terms of what we've been doing. John is a bit of a Washingtonian when you come right down to it. And actually, you could probably tell I'm not actually at the dockside, but I've picked a picture that is relaying to a dockside. This is actually, if we were in DC, John and I was in DC, we would have this chat on this boat, which I have named the only boat on the U.S. Coast Guard Registry that has the name on background, which if anyone has worked with the press knows that, yeah, let's talk about that, over drinks on background. So finally, I have an answer, having left an administration or two, that I can actually say that. So our procedure today, just for folks who are joining us for the first time, and we are recording this, is that we have 30 minutes of this that's on the record and then 30 minutes off the record. The part that's on the record will be available at the Carlson School's website, usually within a few days after we're done. The expectation is John and I are going to have a bit of a conversation here. There's no PowerPoint deck at all about where things are trending in the industry. And then we will then open it up to broader questions that are there. Regretfully, my compatriot who normally does this with me, Tom Gunderson, is not here, but Tom has expresses some thoughts that he's had, so I'll channel some of Tom's best senses of where things might be. So without further ado, and then I guess one other comment is as we do get into questions, just do the Zoom etiquette of putting your hands up. We're not actually spotlighting us, so that way we get a sense of who's in the room as we go. So John, just to start off for a little bit, just if you could tell a little bit about your journey. Right now, you're the president and CEO of this fabulous thing, but you weren't always that. So tell us a little bit about your background and where you were coming to all this space.
Well, it's great to be with you, Steve, and great to be with all of you. And I see some friendly and familiar faces out there. I'm a pharmacist who really wanted to be a sports broadcaster when I grew up. My mom got sick when I was young, and I was just fascinated about how prescription medicines worked, right? Why did some drugs work and others didn't? Why was the green pill better than the white pill? What's in these things that look like they're the same, size and shape? And before I knew it, my reading took me to applying for pharmacy school. I was very lucky in that the County Pharmacy Association that I lived near encouraged me to get involved in student organizations, was very active politically. And I think, the Brevard County Pharmacists Association has placed a number of American Pharmacist Association presidents and probably dozens of Florida Pharmacy Association presidents. So I'm a pharmacy student. I'm getting very involved in policy and health politics topics. And one day the executive dean of the medical school tells me I'm going to Washington to be the American Medical Student Association's health policy fellow. So that was the summer of 1996, right? I don't even know that I knew the difference between Medicare and Medicaid, as a first year pharmacy student. And I come to DC. It was the year after they had the big Clinton healthcare reform debate. They were writing a law referred to as Kassenbaum-Kennedy at the time, which we now know as HIPAA. They're debating a number of other topics. And every Friday we had grand rounds kind of speakers come in and talk to the 15 of us just very openly, big names like you, Steve. And what happened for me at the end of the summer was I realized two things. One is that every stakeholder views healthcare policy differently, right? If I'm a provider, if I'm a manufacturer, if I'm an insurer, if I'm in a hospital, and most importantly, if I'm a politician or a policymaker, what I value and what currency I use to get what I want are very different things. And the second thing I realized that summer is there were 99 other students in the class who would be better at caring for patients one at a time. And that's ultimately what supported my case of Potomac fever. I came back here every summer. I did my residency up here. And then after that, I joined a drug company as a commercial scientist. And it was very funny while I'm working as a scientist, every now and then I would go to an FDA AdCom meeting, right? Because they're always in the basement of the Holiday Inn in Silver Spring or Rockville, or occasionally on the NIH campus. And I lived in Bethesda, right? So I would go to these meetings and I would take notes and I'd send them to my boss. And I sent them to my boss so he wouldn't think that I was on the golf course instead of at an academic medical center. And lo and behold, a couple of years later, they asked me if I wanted to join a government affairs team that they were building. So I found myself working for a manufacturer doing state policy. I had like the Eastern third of the United States. And one day I was explaining to someone the difference between the House version and the Senate version of the Medicare Modernization Act in a bar at a hotel in Albany, New York. And someone tapped me on the shoulder and they said, "Hey, kid, you know stuff. The people with this job know people. You need to work with the people that know the stuff, not the people that know the people." And that's how I made my transition from sort of government affairs or lobbying, if you will, to policy. And I found myself working at pharma in state policy, had a great run there. Not only did we implement Medicare prescription drug coverage, we worked with states to make sure that their SPAPs were going to wrap around the Part D benefit the right way. And then I took a turn and went into academia. I helped Dr. Annie Lynn start the College of Notre Dame School of Pharmacy, or now the Notre Dame of Maryland School of Pharmacy. And because we didn't have students at the time, I was able to serve as a fellow in the Senate. So I would do my admissions committee meetings. I'd write my curriculum, and then I would, go down to the Hill, and that was my practice site, if you will. The ACA passes, CMS gets direct hire authority. I thought I was going to go to work there to learn risk adjustment and payment policy. It was a big thing that I'd always wanted to learn more about. And instead, I found myself working in the shop that manages the delivery of regulations between the centers and the administrator's office. So that's really how I began to learn how the government worked and how policy worked. But when Don Berwick came on board as the administrator, I had a mutual connection with him through his time on the National Patient Safety Foundation. And he also ultimately asked me to join the CMS Innovation Center. When I was there, I got to work with Dr. Isitz. We launched a bold initiative, the Partnership for Patients, to reduce hospital-acquired conditions and preventable readmissions. We saved a lot of lives, saved a lot of money. I met my partner, Ashley. She was working on the readmissions team. And then from there, found myself going to a Blues plan. And that's where I really got to learn the math behind the policy, if you will, and found myself as a VP of policy at Care First, Blue Cross Blue Shield, worked on a number of different payment issues, was really getting into my groove. And then in 2017, I was asked if I would join the administration again. So this time I went in. I was officially the Deputy Assistant Secretary of Health Policy in a really important place. We're going to have a really awesome Assistant Secretary of Planning and Evaluation. And, ultimately, I, led some of the work down in ASPE in your absence, Steve, and then ultimately found myself working in Secretary Azar's office. First as sort of a, catch-all health policy advisor to him, and then ultimately leading his work on prescription drug pricing.
It's an incredible, incredible backstory, an incredible journey that you've gone on too. Since you did mention ASPE, I guess the one comment I always make, because I did not go there, but I did work for the secretaries you did, John, is I'll put my filter on. It takes a lot of money to make a pirate clean. So anyway, I guess I can say that. And I said it in a recorded setting too. So, but I didn't realize you did the legislative fellow thing in the Senate. Let's just dwell on that for a second. I mean, because I did that too, actually working for a Democratic senator. What office were you in when you were actually doing that, or what part of the Senate was that?
I was in Senator Casey's office when he joined the Help Committee.
Okay, Bob Casey, right? Yeah,
yep.
Yeah. So I worked for Rockefeller, if you can believe that, way back when. And again, that was sort of anchored off of when Bush 1 was trying to do health reform, that more or less they outlined a plan with Newt Gingrich and Archer and others that more or less became the foundation of ACA, with the exception of the Medicaid expansion. So it's a rich history. So let's flash forward to where we are now. So one area, I think, as you left the administration, you were tasked with the title of drug pricing czar, not drug czar. That's a different agency. And at that point, I was at the Council of Economic Advisors. We talked a bit about this. I mean, maybe we can leave this for off the record, perhaps as a conversation point. But I guess while we're still on the record, I mean, to what extent do you see things moving in a direction that is likely to make a change in the near future, or do you think we're still pretty much status quo autopilot in that space? Because it seems as though both sides want to do something, they just can't, either from the executive side or the legislative side, kind of move it, basically.
Yeah, I think the original drug pricing blueprint, as it was released in May of 2018, asked a lot of important questions. And I think the goal of that work was to make small changes across the supply chain, whereby every stakeholder would give up a little over here, gain a little over here, with all of the net benefit flowing to patients. I think what we really wanted to solve was what I still think is the most important problem. When Americans talk about drug prices, they're talking about the price that they're asked to pay at the pharmacy counter. And when I compare and contrast that work to what's being talked about today, I see a lot of price setting. I see a lot of other approaches that I can't quite figure out how they actually benefit the patient at the actual counter. So we can talk about that more, in the later session. But I think our goal at the department, when I was there, was ultimately to accrue net affordability benefit to patients. And ultimately, over the course of that couple 3-year initiative, some of the policies evolved, right? I mean, right. When you try to get a policy through the clearance process, the White House gets involved, other agencies get involved. Not everything looked like we originally intended it to look, or ask questions about in the blueprint. And I think one of the most important things I learned during that time, and still reflect on now, is the difference between politics and policy, right? And when I look at some of the bills that are out there today, I think people are making sweeping assumptions in their talking points, and I think they're focused on vote counting as opposed to actually helping people where it matters most.
Yeah, I think it's a really astute observation. I mean, I think as someone, and I know you've worked with academia too. I mean, I've been steeped in it now for 22 years. I mean, I will say that having done even academic administration now for the last 7 or 8 years, that prepared me at least a little bit for working in a vast federal bureaucracy. So at least, I wasn't, nothing much surprised me, but I mean, that whole process of the staff secretary process of kind of moving anything through the different agencies that have even vaguely touched on stuff. Like you just, from the outset, when you think about it, it's like, oh, that's CMS's dominion. You're like, CMS is just one little cog. They can't do everything. Or like anything that involves policy, that involves employers, suddenly gets the Department of Labor involved because they involve ERISA. Anything that involves HSAs involves Treasury because they're setting all the other policies for the health savings accounts. And they all have to more or less agree, on a weekly basis in terms of where things are to have anything fly at all. Let alone just the policy of like, in theory, you're working for an executive that, may or may not really be fully across all executives know where you are. So let's switch gears a little bit. I know part of the title of this was looking at innovation, access, and affordability. And I think I want to get right to the core of this. I mean, you and I both know, and we can see it around the horizon. And I think some people don't quite realize this yet too, that there are $1 million cures on the horizon, right? And this is something that's been touched upon in some of our classes too. It's not clear how our current healthcare financing system pays for them. So when I look globally, for example, and we came up with the hepatitis B basically cures, right? That was an instance where if we look across the pond to the British National Health Service, and people are like, oh my God, that's such an expensive drug. They're never going to pay for that because the NHS is all about rationing. But yet their cost effectiveness models at the National Institute of Clinical Excellence, NICE, said, yeah, we're going to pay for it because we're getting people early enough that their quality adjusted life year saved is going to be enormous. And even though it's super expensive, this is a no-brainer in terms of a quality score. This is like below $15,000. We're good to go. And so it works there, but that's because they think about it over the course of a lifetime. Can you speak a little bit about how you're thinking, or how others you're talking to thinking about, like, how do we do this? Do we really need to have a whole new way of paying for these things, given that a given insurance company might just have somebody for a year or two, and then the buck is passed to somebody else, or even employers might have them for 5 years, and then they go work for somebody else?
And I feel like the last two questions are just a perfect setup for how I got here, right? So
yeah.
The National Pharmaceutical Council's 70-some-year-old health policy research organization. We do research and create evidence to support medical innovation, and we don't lobby. We don't have lobbyists, so I can kind of be out of the political fray again. But our team of experts really tries to follow the data and answer some of the questions that you're asking now. And you're right. We have a lot of incredible innovation today, and we have a drug benefit system that was built to pay for statins and high blood pressure drugs. And I think being part of the conversation about what that future should look like is an important thing that we do here. I don't have a silver bullet answer for that. I can tell you I'm looking at a lot of different models. I'm looking at those models against the backdrop of the CMS value-based pricing initiative. Whether or not we can truly enter into value-based models, whether we need to have a national pooling approach as opposed to what's been laid out now, as well as figuring out if there are alternative mechanisms that have the ability to follow people around, right? And there's a lot of thinking around, tradable permit type concept. So I don't have an answer. It's an important question. It's something that we're thinking a lot about. But your example of hepatitis C, really reminds me about one of the most important things that we have in our system, and that's the value of competition. When I was at the Blues and Sovaldi came on the market, right, it was $84,000 drug, $1,000 pill. Within short order, we had a competitor, and we saw a 40% decrease in the price of that class. And I think now states are paying somewhere between $12,000, $13,000, $14,000 to cure hepatitis C. And I think that's the important thing. I'm here today on the heels of this pour over the last 3 days. Sure. And when you start to talk about how these models are built, right? thinking about how to capture all of the value, and not just sort of a one size fits all quality approach is something that I think is also going to be very important as we think about what that future looks like.
And so those out there who aren't quite nerding out like where John and I are, ISPOR stands for
the International Society of Pharmacoeconomics and Outcomes Research.
Yeah, which is it makes sound like only 20 people would be there, but how many people were there, John? Is it probably like 4,000 or 5,000, or is it?
God, I think they had 3,700 in the room, another few thousand online. There were 57 countries represented,
Right.
in the building, and 53 on the live stream. But what this meeting said to me in 2022 is that once upon a time, 50, 60 years ago, this was a very small community writing in very obscure journals. But the future of health policy is really intertwined with these conversations. And I think you're starting to see more people with a policy bent starting to dig deeper into how to understand these models. And most importantly, how to speak honestly about what they tell us and what they don't.
Yeah. So one thing I want to touch on. So this is an issue that nags at me a little bit, and if we want to do it off record, that's fine too. But I mean, you were there with ACA when it got passed. I was around for that stuff too. And one of the compromises that was made, mostly, I guess, to get it to pass, but it was, if I remember, it was Sarah Palin sort of led that drumbeat for like deaf panels. And for whatever reason, we basically said, we're not going to do cost effectiveness analysis. We're going to do comparative effectiveness analysis. And it's not for whatever reason. I know exactly what the reason is, but the rest of the world that shows up at ISPOR, I mean, those people, that's what they do. I mean, that's what they're trained to do. They have different national models or different either industry models to operate that way. Do you think that, I mean, is this something that we can, in this country with CMS or other people, sort of just say, okay, we need to like now talk about these things more openly and call them what they are, or just, keep on kind of playing, in my mind, this sort of shadow theater of not talking about cost when really the rest of the world gauges everything that way. So
I think there are some real risks in giving the government the authority to say, we've done this analysis and we therefore deem this to be the price of a drug. I think there are, some good international examples of things that started with perhaps one purpose and have evolved into being a cost-cutting mechanism. The challenge that I have with some of these approaches, or trying to compare us to other countries, is every country incorporates their preferences. And one of the preferences that we have here is early access to new innovation. And, I was traveling in New Zealand, I think it was 2005, 2006, and recalled their health ministry deciding that they weren't going to cover a really valuable breast cancer drug because they felt that it didn't meet their quality-based willingness to pay threshold.
Sure.
And if you look back at what we've done in breast cancer here in the United States, I'm really grateful that people like my mom had access to that kind of treatment. So I think there is a conversation to be had about what is the role for some of these concepts in how we do things. How do private payers look at them? How do government payers look at them? What are some of the risks that are involved there? But my time in government reminds me that things have a tendency to get really political really fast. And then that's when, as a health policy person, you start thinking about the slippery slope.
Yeah, that's dead on, I think, actually. I mean, I think and even just in the US too, I mean, it's not just one big country that we sort of, this is the one thing I always talk about in my own classes. It's like, the UK has a fairly substantial, I mean, there's some variation in terms of the UK, but it's not as much as what you'd see in the US in terms of where things are, in terms of federalism as a project. Even when I sort of visit the UK and other places, are like, it's like we say we're the United States, but understand that each state has a constitution, and a lot of that matters in terms of financing, particularly when it matters for healthcare. So we're running toward the end of our half hour, but I wanted to give you an opportunity, given your career as a pharmacist, and I know several people here are pharmacists that are, as students that are here that are engaged, and also MBAs and alums of the program. What would you say is the best reason to, get in this industry, stay in this industry, be excited for this industry going forward? What keeps you excited about it, I should say?
We now have medications that allow patients with cancer to take a pill instead of getting chemotherapy. We've made some cancers chronic conditions. We've turned HIV/AIDS into a chronic condition, and we are literally using CAR T-based therapies to take people's own blood cells, train them to become cancer-fighting ninjas, if you will, and go back into the body. We are on the cusp of an incredible amount of innovation. And from a science perspective, that makes it really exciting. But to bring it back, what you talked about, right? Our system today is built on an old way of thinking. And, just the conversation about, Medicare Part D. Medicare Part D doesn't have an out-of-pocket limit for patients. So when they benefit from a convenient medicine that's now available to retail pharmacy as opposed to a clinic, they have very different cost-sharing exposure than they would if they were receiving it under Medicare Part B. So we need bright minds thinking about the future of reimbursement, the future of benefit design, and the future of how to do some of the stuff that needs to be done to be able to make sure that people are able to maintain access to some of the science that's coming down the pike.
Yeah. And I guess the last question really relates more to your current job is in the manufacturing space. I mean, this is something I know got discussed a little bit in the administration too. I mean, how concerned are folks about supply chain issues at all in terms of global supply chain issues? I mean, right now we have Ukraine about to create a massive agricultural supply chain problem. But I mean, is it something that we really should be concerned about, do you think? Or is it something that's just, it just gets more news than it needs to?
That's never really been one of my core issues, but I've certainly watched the conversation become even more important, right? The advantage that globalization provides you is the ability to take advantage of certain features and benefits of other countries in your supply chain. And that works really well until that supply chain is interrupted. So I've heard sort of a number of strong cries from different sides of the spectrum as it relates to the should we be doing more manufacturing in the United States conversation. I think there's a separate conversation about, regardless of where we make the medicines, do we need a better approach to having a stockpile? Should that stockpile be a subterranean bunker, or should that stockpile be the ability to tap into a ready-made supply? So I think if the pandemics taught us, pandemics taught us a lot of things, but looking at the supply chain and how it functions is I think going to be a conversation for the future as well.
Awesome. Well, that was a fairly quick conversation. We're pretty much at the bottom of the hour here. I'm gonna ask Jessica if we can take us now off the record